Thank you so much. So thank you. It's really an honor to be here. Thank you for the kind introduction. And thank you all for staying so late. So I will try not to be too long. But my task today is to talk about the best of TLM on hepatocellular carcinoma. So here are my disclosures. I don't know how to move oh, wait. I got to learn how to use the slides. Okay, I have no disclosures of my own, but I will disclose that this is a very large topic. There was a lot of very exciting abstracts that were presented at TLM. So, you know, it's difficult to choose, and there was certainly a lot that we miss, but I only have a brief time. And essentially, these were chosen by Lauren Nephew, who gave the HCC debrief. I also took slides from Nihar and, of course, abstract authors. So we'll review the epidemiology, risk stratification, and HCC therapy. Okay, let's start with epidemiology. So we know that HCC remains a global problem. And in this slide that was in the 2023 guidelines, which really predates, it was a publication from 2021. You can see that globally there is hepatitis HCC, but you can see that the etiology is very different. This is mostly driven by viral disease. And so the majority of the world, the predominant reason for HCC or the risk factor is hepatitis B and C. Now, there was an abstract that was presented Abstract 3019, which looked at the idea of predicting what is the future. Because we know that the etiology of primary liver cancer has been changing in the adults, and that now viral disease may be in a different way. And so the idea is to use present temporal trends to predict what is in the future. And they used the global burden of disease study data from 1990 to 2021 to describe the trends, and then try to use this new technology, well, maybe not new, this joint point regression to try to forecast what is going to happen in 2050. So essentially, they wanted to predict the age-standardized incident rate as well as age-standardized mortality rate. And so you'll see here that, probably not too surprising, that right now, the majority of HCC is underlying by Hep C and hepatitis B. But the prediction is that in the future, this will be mostly MASLD. And so not surprisingly, depending on the prevalence of MASLD, MASH, the likelihood is that in the rest of the world, there will be a decline in HCC in 2050, but that there will be an increase in the Americas. And so, you know, I think this is something to keep in mind as we move forward. So talking about risk stratification and screening strategies. First, it looks like that the disease is trending and becoming very different, but the reality is today, hepatocellular carcinoma is a very big problem. It's the sixth most common cancer in the world. It's, however, the third most leading cause of death because we mostly capture them at a point when they're not curable. And I think that we all recognize that the highest risk is the amount of liver disease that you have. And so in this study, I think this is using liver stiffness and cancer risk stratification with MR elastography. This was a study that was trying to see if the stiffness measured by MRE would be associated with HCC. This is a single center retrospective cohort of 2,037 patients who underwent MRE. They had regular surveillance, and multivariable Cox regression was used to predict HCC. And as you can see here, not surprisingly perhaps, the hazard ratio per kilopascal in MRE was much higher for decompensation and overall mortality. But I think what is important for this particular abstract was the risk of HCC. And they had cutoffs that help you sort of cut off what is the increased risk. Now, this is not really surprising. You could probably, this higher MRE measured liver stiffness independently predicted incident HCC development. But I think this really just confirms what we already know, which that liver stiffness measured by probably any measure, including FibroScan and ARFI, would support as a possible way to risk stratify your patients. At the present time, we use the qualification of cirrhosis, but the reality is that the higher the stiffness, the more the risk, and that we use an arbitrary cutoff of what we think is cirrhosis. Now, going to the idea of surveillance and screening, I think this is just data from the hepatology guidelines that showed that screening does reduce mortality, right? So in the left side is the only data that's a prospective trial. It's on hepatitis B patients, and what you can see is that there were none that were caught. There were none in the control group, but in the screening group, there was patients with HCC. So these are stages of HCC at the time of diagnosis. You can see that for those people who are stage 2 at diagnosis, there was an improvement in survival for earlier diagnosis. In the rest, this was hepatitis B, but in the rest of the studies was the meta-analysis that showed that there was improvement with screening. So this is a justification for surveilling patients who are at high risk. So AASLD, of course, the present guidelines suggest that we should do surveillance in patients who have greater than 1% per year of HCC, and these are generally cirrhotic patients and hepatitis B patients with high risk. So the guidance from AASLD recommends both ultrasound and alpha-fetoprotein every 6 months because only 40% of patients are diagnosed at an early stage. And ultrasound alone gives you a 45% sensitivity, but the addition of alpha-fetoprotein with ultrasound increases this to 63%. So these guidelines have been here for almost a decade or more, and they are global. Everybody recommends either ultrasound or ultrasound with alpha-fetoprotein. But despite that, we all know that it doesn't really happen. So in this study that was also presented at TLM, this is a study from India. So they looked at, what is in a 3-year prospective cohort of consecutive patients with cirrhosis. They looked at what was the adherence rate and looked at factors that determine that. So the full adherence to alpha-fetoprotein and ultrasound in this prospective cohort was only 9.1%. I think that kind of reflects what you would believe, and that partial adherence was better. If you just did ultrasound only, that was 47.5%. And they looked at why. So the majority of them is that it's not advised by the treating doctor. So it wasn't just not, it's an asymptomatic disease. People are just not getting surveyed because, people don't order it. Of course, access is a problem, right? Financial and no access was one of the reasons. So the takeaway is that fewer than 1 in 10 adhere fully to HCC protocol. Now, you may say, this is because it's in India. There's a low resource country, perhaps. Well, you have the same study in the United States, except that this is a retrospective of an insurance database. And in this large cohort of retrospective study, you can see that there were 270,000 patients in this cohort. And what is interesting is, look, only 9.9% got an ultrasound and alpha-fetoprotein. Now, in the US, more people got MRIs and CTs, so if you add those up, you can consider that about 35.9% were ever received any surveillance in that first year after they're diagnosed with cirrhosis, which is like probably the time when people get most likely to do it. But you can see that over time, it seemed about the same. And in this particular case, I think what we saw was that the likelihood to get surveillance was essentially whether you were seeing a doctor, a GI doctor. because GI doctors are more likely to realize. But the majority of cirrhosis patients are in primary care. They are not seeing a specialist. So I think it's important to recognize that we are doing very poorly with this. And that is why I think we need to think about, the reality of it is these recommendations have been here for a long, long time, but adherence is bad. Why is that? Well, all my patients, you send them for ultrasound alpha-fetoprotein. They almost never get the alpha-fetoprotein. How many times do I have to tell them, you need a blood test too? But somehow it never happens. It's just very inconvenient. And so this was a paper that was published by Amit Sangal, and it basically, you have to reframe yourself, right? The effectiveness of a strategy depends on how many people actually use it. It's not just sensitivity. So the strategy of ultrasound alpha-fetoprotein, let's say only 25% of the people get it. Then there's only 60% effectiveness, right? If you use MRI, which is great, but who can afford it? If you have a 15% utilization, even though it's a fantastic test, 80% sensitivity, it's only a 12% effectiveness. And so I think people are beginning to recognize that maybe we need something easier. Maybe just a blood test would be easier. And so there were a lot of abstracts in that category. So if you did a blood test, you may not have to be as good as ultrasound and alpha-fetoprotein. But even then, you would get a much better effectiveness if you could just get more people to use it. And so there are several. GALAD here is a combination equation using demographics, uses alpha-fetoprotein L3 and DCP. And this was developed in the UK, mostly with Hep C, ALD, and MASLD, and was published in 2014. And it has been used and validated in multiple Asia and US cohorts. And other than low performance at hepatitis B, it's done very well. You can see from the AUC that it's actually quite good a test. In the United States, this has been FDA approved, actually. You can just order it. And in fact, there's a pragmatic trial, a phase 4 pragmatic trial that's undergoing right now, and we're eagerly looking for those results. But at AASLD, the following was presented. This was abstract 252. What they did was use the 3 components of GALAD, alpha-fetoprotein L3, and DCP, and what they were interested in is whether, can you just use one of them versus all 3? And of course, there are many different models using those 3, including GALAD, GALP, ASAP, and AMAP, DOISDOM, and they looked at the performance for HCC detection. And this cohort used the UK Biobank case control study of 442 patients. So what they found was, here's the AUC curve. So the takeaway here is that composite scores, which use different equations, seem to do much better than the individual biomarkers. So alpha-fetoprotein alone did not do as well if you did a composite of all 3. It seemed to improve it. So in this study, GALAD actually offered the most consistent diagnostic accuracy with different cutoffs, and also in non-viral disease and early stage HCC detection. I think this is important because this would be a blood test. It's now is going to become widely available, and so it's something to think about as we look forward to the prospective phase 4 study. Now, we have ultrasound alpha-fetoprotein, we have serological markers, but the newer, novel, advanced way is perhaps the idea of circulating tumor cells. So we know that circulating tumor cells are present when you have HCC. And so you can measure those cells, which is a little bit harder, or you can measure the circulating tumor DNA, because that's more stable. And there are many different ways to do this that people have looked at. Methylation patterns is one of them that has come up really well, and 2 abstracts were presented at AASLD in this regards. So one of them was a late breaker. So the idea was to use this is a methylation technique. So they use cell-free DNA methylation patterns to see if this, in addition to alpha-fetoprotein, could improve accuracy. And this is a novel blood-based assay And they used a prospective cohort of 135 individuals with HCC and 167 at-risk patients. And what they found was that the diagnostic performance was actually quite good. It outperformed alpha-fetoprotein. So if you add methylation markers to alpha-fetoprotein, it improved the outcome, as you can see, both for overall HCC detection as well as early stage. So these results really support the use of combining methylated cell-free DNA with alpha-fetoprotein to improve HCC detection. Another very exciting study, again a late breaker, was the ATLAS study. This was something that everybody's been looking forward to for a long time. This one is a proprietary methylation panel. This is called OncoGuard. You probably have heard of it, but it's blood-based. And again, they also use the combination of alpha-fetoprotein with DNA methylation. This was a multi-center prospective study of adults with cirrhosis undergoing routine surveillance. And what they found was that this marker with alpha-fetoprotein outperformed alpha-fetoprotein in ultrasound. So you can see that the sensitivity was much higher in the blue in the right panel compared to alpha-fetoprotein alone or alpha-fetoprotein with ultrasound. And this was also as well as, it's particularly good in those patients in the panel in the middle. You can see that it was particularly good when it was a less than 2 centimeter lesion, which makes sense because of detection on ultrasound. So the takeaway is that this methylated cell-free DNA methodology with OncoGuard, as they say, demonstrated superior sensitivity for early stage HCC compared with ultrasound, and it maintained the same specificity. So I think these are very exciting findings that I think in the future could have a space, particularly if it could improve surveillance adherence. So last but not least is therapy. So, we are still doing very poorly with overall survival. And this is just a reminder that the two abstracts that I wanted to look at was in terms of immunotherapy. You know that we have suffered with multi-kinase inhibitors for decades, and finally, almost just recently, we now have 2 in the guidance, but now 3. So Tezbev, durvalumab, tremelimumab, they're all immune therapy based. And the most recent one is the checkpoint inhibitor nivolumab and ipilimumab. I don't think I can pronounce any of those things. But this is the results of the Checkmate 9D that was already published. But this at AASLD, this was also presented, for first-line therapy. So this was an pre-planned interim analysis of a phase 3 study from the Checkmate 9D study. And here they present data on hepatic safety and benefit risk of nivo-ipi versus lenvatinib or sorafenib. These are adults with HCC with no prior systemic therapy who were randomized 1-to-1 with nivo-ipi, 4 cycles, it's the classic, followed by nivo alone, and an investigator's choice of either lenvatinib or sorafenib. Liver function was assessed by the ALBI score over time. So, as you know, the study showed an improved survival benefit of nivo-ipi versus lenvatinib sorafenib with the median survival of 23.7 months versus 20.6 months. So this was a positive study. And in this study, they looked at, what were the hepatic risks. So there was an 18% reduction in the risk of hepatic deterioration with nivo-ipi versus TKIs. And you can see on the graph on the right, that the nivo-ipi did better in regards to hepatic dysfunction. Now, it's interesting because immune-mediated hepatitis did occur in like 19%, with 15% being grade 3 and 4. But overall, that still was showed improved survival. The median onset was 6 weeks after being given Nivo-IPI, and a median resolution was 10 weeks. So the take home is that Nivo-IPI is now our third systemic therapy for unresectable HCC, and was actually manageable across ALB subgroups with preserved liver function during therapy. So one of the most interesting things is the idea of, can we use this in other than patients who are not eligible for local regional therapy? And this was in the area of transplantation, because there was this idea that perhaps you can downstage with systemic therapy, or you could use this as a neoadjuvant therapy. So in this study, this is a retrospective, 60 centers worldwide. They collected all their HCC cases. Now, this is not a pre-planned thing. Just anyone would treat it with ICI to give us some idea. And this was in the context of downstaging or bridging to liver transplant. And they looked at recurrence-free survival, overall survival, and rejection-free survival. So in this study, the median number of cycles that you got was 4 cycles of immune therapy, and the washout median time was 72 hours. So washout is between the time that you finish therapy versus when you get the transplant. And the outcomes, there were 28% overall recurrence, 17% rejection, and 22% over 1.6 median follow-up. So they looked at what are the key predictors. For higher recurrence, it was most likely if your alpha-fetoprotein was elevated, and hepatitis B, and those who are beyond Milan, which is not too surprising. This is the presentation of the 1-year and 5-year overall survival. So if you are able to be within Milan criteria and alpha-fetoprotein of less than 20, then I think these are very, very promising results. And so, I think this is sort of the beginning of us understanding how to use ICI before transplantation. So the idea is if you can achieve it achieving it by decreasing Milan criteria and lowering it. So you have to select for the patients that can do it. The other thing is really recognizing how long do we have to be, have that washout period, because the rate of rejection can be quite high. So the takeaways: global burden of viral hepatitis-related HCC is projected to decrease, but there will be a concomitant increase in mast cell-related HCC. Risk of HCC in chronic disease, of course, is related to the severity of liver disease, and it may not be an arbitrary cutoff, but rather the continuous cycle of liver stiffness. Our real-world adherence to surveillance using ultrasound-based screening remains really poor, but promising results are being shown with the use of, I should say, plasma biomarkers. And there is exciting progress in the use of systemic therapy in HCC, including checkpoint inhibitors, both as primary therapy and neoadjuvant prior to liver transplant. So thank you very much.